Welcome back, class. We're going to spend just a few minutes talking about the ethical dilemma, or what could be an ethical dilemma from the payer's perspective. And again, when I'm talking about payers, well, you've got CMS and you've got the states. You've got CMS at traditional Medicare. You've got states that pays for Medicaid. You've got other government agencies that pay for government, programs, TRICARE with the DOD and the VA with the Veterans Administration. When I'm talking about payers, for the most part, I'm going to be focusing on health plans in the private sector that not only um, provide private sector health plans or benefit plans to employer groups, but also has some Medicare Advantage and some Medicaid business, may have some TRICARE business and some VA business, but they're not typically government agencies. It's more in the commercial side of the house. So um, again, I've mentioned it on probably more than one occasion. Health plans serve as a clearinghouse to ensure that buyers and sellers of healthcare services perform according to the contracts. And that is one of the um, main attributes of a health plan. It brings typically employer groups employ and their employees. It may have some Medicare Advantage plans, again, may have some Medicaid, but it's bringing all of their customers that have signed up with that health plan together with the providers. And again, they're functioning as a clearinghouse to ensure that both sides, because you've got the consumers that have the benefit plans that they purchase, you have the providers that have signed contracts, negotiated and signed contracts with health plan. You're bringing them together to provide. And again, the focus is you want to provide high quality, affordable health care to all members. And that's the rationale that you have these health plans bringing these two sides together in order to provide that type of healthcare goods and services. Your health plan CEO should establish a culture based on morality and ethics. And fortunately, I've worked for um, CEOs that have been, on the high road when it comes to morality and ethics. Blue Cross Blue Shield, the CEO, and there were on multiple occasions I would take an issue to him as man is directing this payment integrity function. I would take issues, to either typically it was the chief actuary and the CFO, but sometimes to the CEO. And I'd say, look, we've got a glitch in the system and it's paying these claims incorrectly. We're shorting the providers X number of dollars because of the way the system is set up. And there was never an instance that they didn't say, well, go back in and reprocess those claims, reach out to the provider and tell them, hey, we found a glitch in the system. We're going to correct it and we're going to back pay you all of these claims that we processed incorrectly. And that is taking the high road from a health plan's perspective when it comes to the moral and the ethical aspect of healthcare goods and services. And when it comes to providing this high quality, affordable health care to all your members, that's to some extent, it's going to be a function of either the network management team as they negotiate contracts with providers, or the medical management team, which is the clinical aspect that's going to determine how to bundle these healthcare goods and services in such a way to drive an individual's selection of high value healthcare goods and services. Now, if your network management team is not astute in negotiating contracts, or they have some ulterior motive in mind, and I've seen this happen before, you will have you'll have a situation where ethically they aren't doing their job. That's they're not doing an efficient job. They're not supporting both the health plan or the members that are consuming these healthcare goods and services. I can remember, and this was when I was developing a network for Aetna in Southern California. Went into one of the major hospitals. There's you got the two systems in Southern California, that San Diego area. You got Scripps and Sharp, and went in and you know sat down and negotiating with their contract negotiator. And I went in and I at the time I worked for a retired admiral who was a psychiatrist, and um, this individual that I worked for, we had a great good cop, bad cop situation set up with all of these providers in Southern California. I was the bad cop. I was the economist. I'm the one that set the rates. I went in and I would negotiate. Providers would, complain, and I'd say, yeah, this is what it is. Take it or leave it. They would turn around and they would call the the retired admiral, and the retired admiral would say, well, this guy, he's a little over the top. He's, I'll whip him into shape. I'll whip him into shape for you, and uh, I'll see what I can do on the rates. This individual, don't want to mention any names, but he would come in, he'd sit down, and he'd look at me and say, "Okay, what'd you do?" And I'd lay out. I said, "Here's the rates." I said, "We talked about these rates before I went in to talk to him. This, hospital system." He looks at me and said, "Yeah, I remember." So said, "You must have really driven a hard bargain." I said, "Well, I I thought it was a reasonable thing to do. Uh, I have a fiduciary responsibility to, at that time it was Aetna. I have fiduciary responsibility to Aetna. I have fiduciary responsibility to the TRICARE members, or the Champions, at that time Champions members that we were providing healthcare services for." He said, "Yeah, I know," but said, "You might have gone in a little rough," and said, "What if we do this?" He laid out everything. I said, "Well, uh, we're still gonna make money." Um, then then Jim said, "You understand the information," and he said, "Sometimes I feel like we're taking advantage of these providers because you understand the information, and it's easy for you to develop these rates and these contract strategies." And said, they don't understand it. I said, "Well, it's that's a business world." And so he would go back, he'd say, "Well, here's what I can do. How about I get you these rates?" And the provider would say, "Oh my God, that is great." And so we still got rates, not where I would have liked to have had them, but pretty close to where we liked to have them. Again, remember we were setting, when I talked about the providers and the payers setting that contractual um, in the range when they negotiate. And somewhere along the way, I went in to talk to, and we've had a really difficult time with this hospital system in Southern California. And I put some rates together. And I went in, sat down with the admiral. And I said, "Here's what I'm going in with." He said, he looked at me and he said, "There is no way in the world we'll ever get these rates. No way in the world we're ever going to get these rates." And I said, "Well, I'm gonna give it a shot." So I said, "You can expect to get a call." He started laughing. He said, "Well," he said, "I've come to expect it." He said, "I kind of enjoy them." I said, "I wouldn't tell them that, but I enjoy, getting the calls." And so I go into the hospital and sit down, and I lay out the rates and I give them all the rationale. And um, the individual on the other side of the table looked at me, and she kind of looked around the room and she said, "Okay." Took out her pen, signed it, said, "Take it back, get it signed. We'll make this thing effective." I took the contract back, and went into the admiral's office, and I said, "Here, sign this." He said, "Accept it?" And I said, "Yeah." I said, there's something. There's something not right. I said, I can't really put my finger on it, but I said, but there's something not right with this whole process. And you feel like it. Have you ever um, well, just like gone to sell a car or gone to sell a house, and you put it on the market. Let's say you put your house on the market, and you uh, put it on for a rate that seems pretty reasonable to you, and the first person that walks in the door buys it just like that. And at that point, you're second guessing yourself that I priced that too cheaply. But Jim and I both, we were looking at these rates and we said, there's something that, he said, there's really something wrong here. So why in the world would you have done that? Well, about a week later, get this, get this email from Aetna's corporate office. And this individual had gone to work for Aetna as their network manager on the commercial side in Southern California. And I went in, showed Jim the email, and he looked at it and he said, man, this probably isn't right. Says, she knew that she was going to work for her. Then it was like, well, and those are ethical things that you run into on the health plan side, because the health plans, as I said earlier, they are there to make a profit. I don't care whether it's a for-profit healthcare provider or a not-for-profit healthcare provider. If you're a for-profit healthcare provider, you're there to make a profit and make as large a profit as you can to drive earnings per share because you have equity investors involved. If you're not-for-profit, you still have to drive profit and make money so that you can ensure the long-term viability of a not-for-profit health plan. And that is where things get so confusing for certain individuals within the health plan. And then kind of lastly, on the payment integrity side, and again, my payment integrity team at Blue Cross Blue Shield, we had fraud, waste, and abuse, we had contract compliance, we had other party liability, which was coordination of benefits and workers' comp and motor vehicle accidents and subrogation. We had clinical editors that ensured all the claims were processing correctly. And that payment integrity shop was built on the premise that if a claim came through the system that had not correctly adjudicated, that we would ensure that it would adjudicate correctly. And if it meant that it incorrectly adjudicated in favor of the health plan, we would go back and re-adjudicate it and pay the providers what was owed them. And vice versa. If it adjudicated incorrectly in favor of the provider, we would go back to the provider and recoup that money. Because not only were we recouping money for the health plan, we were recouping money theoretically for members, especially those that had co-insurance or had deductibles, and for these, and for the employer group, and I'll explain the employer group piece of it. So with employer groups, you typically have either fully insured, and when you're talking about fully insured, that's where the health plan takes financial responsibility and we charge a premium to the employer group, or you had self-insured employer groups, which they contracted with the health plan to adjudicate claims, build provider networks, provide medical management, provide legal information for a certain fee. And then they accepted the responsibility. That's why they called it self-insured. They accepted the responsibility for all of the healthcare costs. And so when you re-adjudicated those claims, those dollars actually go back to the employer group. So from a payment integrity perspective, that is the moral and ethical approach, is to make sure that as money flows out to the providers or money comes back into the providers, that it is reallocated across all of the impacted actors within that healthcare environment. And then the last thing, when you're talking about, especially on the payer side, and we'll get into it some on the provider side, because in some areas, and Buffalo is one of them, where the talent pool for individuals that could help, especially on the payment integrity side, was really shallow, you would contract with third-party vendors and build relationships, and they would help supplement and or complement your internal resources in order to ensure that all of the loopholes were closed on the payment integrity side. And not only were they providing resources to help you, you were building human capital internally because you were, in most instances, able to re-engineer what they were doing, and that enabled you to be more effective with your internal resources. Not only did it build your marginal product of labor, but it was actually maximizing your average product of labor. So third-party vendors, and there is a huge network of third-party vendors working on both payer side, the provider side, and to some extent, they're doing work on the public policy side, especially with government agencies like CMS. They're doing work for them, especially CMS on the traditional Medicare side. And so that's going to kind of wound us up with on the payer strategies. And we've probably got a couple of three more. I know we want to talk about public policy. I know we want to talk about the provider side of the house. And I think the next segment, we're going to talk about public policy. Talk to everybody in a few minutes.